So the question is, when do you start seizure medications and when do you stop them? Let me just, okay. So just a brief overview of the objectives here. We're going to outline the epidemiology and definition of seizures very quickly, as I was obviously covered earlier this morning, review the risk for recurrent seizures after a first-time seizure, and discuss the risks of seizure relapse after anti-epileptic drug withdrawal. And so as was touched on earlier today, a seizure is the symptom, so defined as transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And epilepsy is the disease. We have the International League Against Epilepsy published definition of epilepsy from 2014, that you can get to the definition of epilepsy in multiple different ways. 2 or more seizures more than 24 hours apart in a lifetime, 1 unprovoked seizure, and something suggestive of an increased risk of recurrence of seizures. And the reason to keep this definition in mind, because this brings up the question of when do you start medications in patients. As was reviewed, epilepsy is a very common disease. Single seizures are relatively common, occurring up to about 10% of the population, and 1 in 26 people will develop epilepsy at some point during their lifetime. For the most part, patients can be controlled with medication, 60 to 70%, and so that'll be what we'll be focusing on is the medication. And in terms of age of onset, can really happen at any age, but certainly the highest risk is earliest in childhood, but after age 60 as well. So it's very increasingly becoming recognized and common in the older population as well. When we're talking about seizures, when someone presents, the first question was this a provoked seizure or was this an unprovoked seizure? So seizures that occur in the provoked setting can occur directly as a result of metabolic derangement, so severe hypoglycemia, severe hyponatremia, any kind of acute neurologic illness, so meningitis, intracranial hemorrhage, head trauma, or it can occur with intoxication as well, whether it's alcohol or drugs. And so in these settings, if you have a very clear provoking cause, you're not going to treat that as a sustained risk for seizures necessarily that would require medications in that setting. When it's an unprovoked seizure, though, that's when there's no immediate preceding cause, and this is when the question comes in, what is the risk of recurrence in this patient of further seizures? So this was a study looking at the risk of recurrence of seizures after the first one that occurred. And so if you look at acute symptomatic seizures, and this is more in the setting of at the time of intracranial hemorrhage, at the time of an acute stroke, a time of acute meningitis, the risk of recurrence, it's still there. They could potentially develop seizures unprovoked later on in life.